Hello everyone and welcome back to the MadMax channel. Let's begin Cardiology Part 6, and this is Chapter 1 of our Supraventricular Dysrhythmia series. If this video reached 10 likes, I will upload a complete, well-structured PDF with everything we covered today. Clean, organized and perfect for studying. I'm trying to do as much illustration as possible because I am a person which memorize much better when I see something, not hear something. But if you see and hear something, it's work much better. First main idea, all dysrhythmia in cardiology can be divided into three major categories based on where they originated. A. Supraventricular rhythms above the ventricles. These come from the atria or the AV node. They usually produce narrow QRS complex because the ventricles themselves depolarize normally. B. Ventricular rhythm below the AV node. This arrives in the ventricles. They are generally far more dangerous because they directly compromise cardiac output and may rapidly progress to life-threatening conditions like ventricular tachycardia and ventricular fibrillation. C. Blocks or conduction disturbances. These involve problem in electrical transmission through the AV node or his Purkinje system. These rhythms are not extra beats. They are delays, failures or disconnection in electrical conduction. These three branches form the foundation of everything we study in dysrhythmias. Once you understand this vision, every rhythm becomes easier to recognize and interpret. So let's discuss the main three. This is the way how I understand and memorize this topic. On the left side of our mental map, supraventricular rhythm, which means faster, slower, irregular or chaotic, but generally less immediately dangerous. On the right sides, ventricular rhythms, the ones that can collapse blood pressure and require urgent intervention. And of course, blocks in the middle. This is just a map, this is how I memorize it. This three is the backbone of rhythm interpretation. I think it's enough with input data. Let's switch to today's lesson topic, supraventricular dysrhythmias. As we discussed before, supraventricular rhythms start above the ventricles, either in the atria or in the AV node. They typically produce narrow QRS complexes because conduction through the bundle branches is preserved, although they usually less dangerous than ventricular rhythms. They can still reduce cardiac output and, in the case of atrial fibrillation, dramatically increase the risk of thrombus formation and stroke. So, let's break all of them down. And we start from sinus node problems. It includes, first, sinus bradycardia. This originates in the CA node, the natural pacemaker of the heart. Heart rate is under 60 beats per minute. The rhythm is regular, the P waves are all similar, and PRI and QRS are normal. This rhythm is common in athletes, young healthy individuals, and during sleep. It can also appear with medications such as beta blockers, digoxin, or due to vagal stimulation. We treat sinus bradycardia only if the patient is symptomatic, like dizziness, hypotension, syncope. In case if unstable, atropine is a first line, followed by temporary pacing if needed. Second, sinus tachycardia also originates in the CA node. Heart rate rises above 100 up to around 150 beats per minute. The rhythm remains regular and the P wave often stay visible, though sometimes they start blending into the T wave when the rate increases. The key concept, sinus tachycardia, is never the problem, it is always a response to a problem. Causes include fever, dehydration, pain, anxiety, anemia or shock. You never cardiovert sinus tachycardia, you're supposed to treat underlying cause. So following is number 3, sinus arrhythmia. Still comes from the CA node. Heart rate is typically 60 to 100 beats per minute, but the rhythm is irregular, usually because of respiratory variation. The P waves look the same and PRI and QRS remain normal. It is usually benign and often seen in younger people or during deep breathing. And number 4 of sinus node problem is sick sinus syndrome. This is a failure of sinus node to generate or transmit impulses normally. It can cause alternating pattern of bradycardia, tachycardia, long pauses, or sinus arrest. Common causes include aging, fibrosis, ischemia, or structural changes of the CA node. Because the rhythm becomes unreliable, symptoms include dizziness, syncope, and fatigue. Long-term treatment often requires a pacemaker, since the CA node cannot maintain a stable rhythm. So, it was sinus node problem. Let's jump to atrial dysrhythmias, which include premature atrial contractions or PAC. These are early beat originate from an ectopic focus in the atria. The P wave looks different, or it may be partially hidden in the T wave. The PRI for the PAC may be different as well, but the QRS is normal. Premature atrial contractions are usually triggered by caffeine, stress, stimulants, or hyperthyroidism. They are usually benign but may precede atrial fibrillation if frequent. Treatment focuses on reducing triggers, and beta blockers can be used if symptoms persist. Now is more dangerous atrial tachycardia. This rhythm comes from a single atrial focus firing rapidly. The P wave is often hidden in the T wave, and the heart rate ranges from the 150 to 250 beats per minute. The PRI becomes indeterminate, but the QRS remains narrow. Atrial tachycardia reduces cardiac output because the atria cannot contribute effectively to ventricular filling. Common causes include digoxin toxicity, electrolyte disturbances, stimulants, and hypoxia. Treatments include vagal maneuvers, adenosine, beta blockers, and diltiazem. The next is Atrial Flutter. This is a single organized reentry circuit in the atrium, producing identical flutter waves. The atrial rate is extremely fast, about 250 to 350 beats per minute. The ECG show classic sawtooth waves, and you must report the flutter to QRS ratio. It may be regular or irregular depending on the AV conduction pattern. Flutter reduces cardiac output and increases clot formation risk. Treatment includes rate control like beta blockers, diltiazem, anticoagulation, cardioversion if unstable, and ablation for long-term cure. And the last of the atrial dysrhythmias is atrial fibrillation, one of the most clinically important supraventricular rhythms. The atria fire chaotically. Just imagine 350 to 600 impulses per minute, creating an regular rhythm with no P wave. Major dangers include blood stasis, thrombus formation, and embolic stroke, especially from the left atrial appendage. Atrial fibrillation management includes same medication for rate control like beta blockers, diltiazem, digoxin, rhythm control like amiodarone and cardioversion, anticoagulation therapy like warfarin or direct oral anticoagulants, and of course ablation for recurrent symptomatic atrial fibrillation. Alright, and the next complex of problems is AV node reentry and node problems, which include Paroxysmal Supraventricular Tachycardia, or for our convenience PSVT. This is a sudden onset, narrow complex tachycardia caused by reentry circuit in the AV node or accessory pathway, often triggered by stress, stimulants or caffeine. How it looks like on ECG. P wave are hidden in the T wave. The rhythms is regular and the QRS is usually narrow unless aberrancy occurs, which means supraventricular rhythm with wide QRS due to abnormal conductions. PSVT treatment begins with vagal maneuvers, followed by adenosine, then beta blockers or calcium channel blockers. If unstable, synchronized cardioversion. And of course, ablation is curative for frequent cases. Next AV node problem is atrioventricular nodal reentrant tachycardia. This means a rapid rhythm caused by reentry circuit inside the AV node. P waves are often invisible or retrograde, appearing right after the QRS complex. The rate is 140 to 250 beats per minute. Rate is regular and the QRS is narrow unless aberrancy is present. AVNRT starts and stops suddenly, which means paroxysmal. Treatment is same to supraventricular tachycardia, vagal maneuvers, adenosine and cardioversion if unstable. And one more problem which I'd like to discuss is atrioventricular reentrant tachycardia or Wolff Parkinson White. It means accessory pathway, which also call it bundle of Kent, bypasses the AV node and pre-excites the ventricles. This produces a short PRI, wide QRS and characteristic delta wave. There are two types of AVRT. Orthodromic with narrow QRS and antidromic with wide QRS. There are important notice. Atrial fibrillation in Wolff Parkinson White syndrome is extremely dangerous and can deteriorate into ventricular fibrillation. Never give AV node blocking during atrial fibrillation plus Wolff Parkinson White. In this case, safe medication include procainamide and, depending on guidelines, amiodarone. Definitive treatment is radiofrequency ablation. So, this is the core supraventricular rhythms. Why it's matter? Because it's frequently asked. Overall, you're supposed to know how to recognize rhythm, clot risk assessment, when cardiovert and when not, and first-line therapy such as adenosine. Almost forget about clinical red flags. Any supraventricular rhythms become unstable if patient displays hypotension, alteration mental status, chest pain, or acute heart failure. It means unstable supraventricular dysrhythmia requires immediate synchronized cardioversion. And from today forward, at the end of every lesson, I will include one very challenging NCLEX-style question, and I reveal the correct answer with explanation in the next episode. Actually, you can put your version in the comments. Alright, questions. A 72 years old patient with a history of hypertension suddenly developed a narrow complex tachycardia at 190 beats per minute. The rhythm is regular and the P wave are not visible. Blood pressure is stable. The patient report palpitation but not chest pain. Which intervention is the most appropriate initial action? Take your time, give your version in the comments, and I will give explanation in the next lesson. If you found this video helpful, please give it a like, put the thumbs up, and of course subscribe so you don't miss the next lessons. In the next video we discuss ventricular dysrhythmias. And once again, if this video reach 10 likes, I put in the description PDF file with structured, good organized all information from this video. This is MedMax channel, Medicine Made Simple.